I'm Dr. Michael Curtis. I'm a research fellow at the National Drug Research Institute, and it is my pleasure to welcome you to NDRI's August webinar, Opioid Overdose in Australia, Evidence, Experience and Emerging Threats. I'd like to start by acknowledging that myself and the three speakers that we're hearing from today are all presenting on unceded Aboriginal land. I'm joining from Boonwurrung country, where NDRI's Melbourne office sits, and I'd like to pay my respect to their elders past and present and recognise their multi-millennia connection to and custodianship of this country and the surrounding waterways. And I'd like to extend my respect to any Aboriginal people who are online today. Tragically, there have been more than 12,000 drug-induced deaths in Australia over the past decade, with more than 1,700 drug-induced deaths occurring in 2023 alone. And this is the year that we have the most recent data available for. And these deaths have occurred at an age-standardised rate of 6.6 deaths per 100,000 people. And while the majority of overdose deaths have involved multiple substances, opioids were the most commonly identified drug class in drug-induced deaths in 2023, having been detected in just over half of these deaths. The majority of opioid-related deaths have occurred amongst men and occur at the greatest rate amongst Australians aged between the ages of 45 and 54. And although the rate of drug-induced deaths, opioid-induced deaths in Australia has been decreasing since 2017, this national trend masks variations between Australian states and territories. While opioid overdoses have been declining in New South Wales and Queensland, overdose rates in other jurisdictions such as Tasmania and Victoria have started to increase again after drops between 2017 and 2020. And it's also clear that the types of opioids involved in opioid-involved overdose deaths is changing, with heroin most recently overtaking natural and semi-synthetic opioids such as morphine, oxycodone and hydromorphone as the most common opioids detected in drug-induced deaths. Every opioid overdose death is preventable. And so to discuss some of the evidence, experiences and emerging threats to how we can reduce opioid-related deaths in Australia, today we're going to hear from Professor Simon Lenton at NDRI, who will discuss evidence and recent developments in the Australian harm reduction initiatives. We'll then hear from Ele Morrison, Deputy CEO at ABLE, on peer perspectives and priorities for reducing opioid overdoses in Australia. And then finally, we'll hear from Dr. Amanda Roxburgh from the Burnet Institute, who will discuss the emergence of novel synthetic opioids in Australia and the implications of this for harm reduction initiatives. And with that, over to you, Simon.
Thanks, Michael. Hold on. Can you guys see my screen now?
Sure can.
Okay, fabulous. All right, thanks for coordinating this, Michael. Look, I'm going to be giving a very quick whip through some recent developments in Australian opioid overdose harm reduction and prevention initiatives. It's not going to be comprehensive. I reached out to a bunch of folks in the last few days just to get some tips and pointers, and I want to acknowledge those. And of course, I want to echo Michael's acknowledgement about traditional owners. I'm coming to you from Wadjuk Noongar territory, and I pay respects to elders past, present, emerging, and any First Nations people who are joining us online today. Look, I also want to acknowledge the Australian drug user organisations and Australian drug users who've been really at the forefront of responding to overdose and prevention of overdose in this country for a number of decades, and have always led innovation in harm reduction more generally, and super great that Ellie's talking after me today. Of course, this is a very old slide, but many of the things on it still hold true. And just a reminder, most people die of opioid overdose because they stop breathing. Being in drug treatment, particularly opioid substitution treatment, is protective. Overwhelmingly overdose deaths involve polydrug use, particularly with other CNS depressants like alcohol and benzos. In 60% of cases, people aren't alone and there's time to intervene. And of course, for every fatal overdose, there are many more non-fatal overdoses, which also have adverse health and other effects. Most people online will know about naloxone now, hopefully, but just in case there's any who don't, naloxone is a medicine that has one job. It reverses the acute effects of opioids, and particularly has effect on respiratory depression, has a long history of use in emergency medicine, and also now, since the 1990s, use in community overdose prevention initiatives. It's a very safe medicine. It's reliable and effective. It doesn't produce intoxication and can be administered by various routes. And of course, since 2019, we've had the intranasal version available in Australia. The history, this is just a quick whip through some of the milestones in terms of naloxone availability. Again, drug user organisations key with this, beginning with CARMA's program back in 2012, and then a number of other drug user organisations and treatment agencies picking up and running programs soon after then. And those guys have been at the forefront of things right the way through. So the developments have been, there's been a cross-sector cooperation and support. There's been a plan to pilot, evaluate and diffuse rather than wait for perfect policy. And we've seen expansion into new settings and new target groups, which has been super important. One of those new initiatives has been in WA, which has been the WA Police Force carrying naloxone. There was a pilot in 2021 and 2022. We did an evaluation of that pilot. There were 272 officers trained in overdose management and naloxone administration, and we saw willingness to administer naloxone and knowledge and capacity increasing greatly. So knowledge and willingness increased from 66% to nearly 100% post-training. We followed up 117 of these folks at 3 to 6 months, and 20% of those had witnessed an overdose since the training, and 70% of people we spoke to in the force had used naloxone to reverse the overdose. It was very well received. It resulted in improved management of overdose and lives saved. And importantly, reduce trauma for police who have to deal with these situations in their workday, and really change the conversation between police and people who inject drugs. Peer-based harm reduction WA folks said that there was many reports from their clients of being really stunned and super pleased that police were reviving them and their colleagues in overdose situations, which is fantastic. So a really great program, which I spoke to Lucas Ride from WA Police yesterday. He said they've had over 140 reversals by police now. There's been no adverse events, and the scheme mainly has been operating in the metro, mainly been reversals in the metro area, where it's carried in vehicles or on the bike team, and with foot patrols in certain areas like Northbridge and other entertainment areas on the person of the officers. There's been over 7,000 training events now, mostly online. That's training events of police staff, and some of the early concerns about civil suits and that kind of stuff really haven't borne out. So it's fantastic. We published a paper on this in Drug and Alcohol Review just this year, and we really were fantastically pleased to see Queensland Police take up the scheme based on the evaluation and reports from WA, beginning their scheme in July 2024. There's been talk in other jurisdictions. I don't know of any other jurisdictions that have been running it. Maybe that's something for the discussion afterwards, but I think it's a no-brainer for police, really. The other program in WA, which is noteworthy, is the St John Ambulance Leave Behind program. So when St John Ambulance staff attend an overdose situation in the community, they deal with the overdose situation, reviving the person, and then are in a position to provide some brief intervention training for that person or their friends and family members who are around, and also train them in the use of naloxone and provide naloxone for management of a subsequent overdose, because we know that once someone's had one overdose, there's an increased likelihood of subsequent overdoses. That's been now rolled out statewide across all their services, and an evaluation that was done comparing ambulance data showed that the scheme did not result in fewer overdose attendances for overdoses, but more patients were discharged at the scene without having to be transported to hospital, and there was no detrimental effect on subsequent survival rates at 24 hours post-overdose. Again, we understand that there's been interest from other services in other jurisdictions. Not sure to the extent to which they've been implemented, but maybe that's something for discussion as well. Peer-based organisations have been getting naloxone out into the hands of people that need it in creative ways, including via postal services. Both Newer and Peer-Based Harm Reduction WA do this, either by online training or telephone training, some questions about knowledge, and then people can get access. There may be other organisations that are also running similar services, really great. Lots of people can't get in for various reasons, and in particular in country areas where it's difficult to maintain anonymity. This is a great service, really fantastic to see it operating and rolling out. The No, people might be aware of, Prompt Response Network, National Centre for Clinical Research on Emerging Drugs, pulling together people involved in monitoring and responding to new psychoactive substances across Australia. Really fantastic bringing together of people and pulling all the drug alerts from various sources and making them available to the public in one place. Can't talk about overdose prevention without mentioning drug checking services, and we know that the drug market is increasingly dangerous due to variable potencies and highly potent new psychoactive substances, including new synthetic opioids appearing in the drug market. We saw, sorry, just to go back, CanTest was Australia's first fixed site drug checking service, which operated in Canberra, began in Canberra in July 2022. Queensland's first drug checking service operated at 2 sites, one in Brisbane, one in the Gold Coast, from April and July respectively 2024. However, both these services, the Queensland services, were closed in April this year after the LNP government opted not to provide ongoing funding. Since 2024, we've had drug checking service operating at Sydney's Medically Supervised Injecting Centre at King's Cross. And early this year, the New South Wales government commenced its 12-month trial of drug checking programs at selected music festivals. Victoria's first drug checking service, funded by the Victorian government, began at festivals in December 2024, and the first fixed site service is due to open shortly, and to open in a location near nightlife and transport services. But as yet, we're not seeing concrete plans to operate drug checking services in other jurisdictions, and that's something which really needs to happen. Obviously, the drug market's changing. We've got a major threat posed by novel synthetic opioids, and we've heard about nitazines and fentanyls and other things, and we've seen them in drug checking services and in other testing that's been done through government and other services. We're particularly concerned about people who don't usually use opioids, particularly young people going to festivals, people at schoolies events, and in other nightlife settings where people aren't expecting opioids. And this is a real area where we need to develop our services, because we've seen, synthetic opioids in drugs like MDMA, cocaine, cannabis, vapes, and pharmaceuticals as well. Really pleasingly, services involved in drug checking and outreach at music festivals are now doing outreach around naloxone, so naloxone overdose prevention and management training and providing naloxone, which is fantastic. Here's a side of Karma's services where they plug that naloxone training is available, which is fantastic to see. And the other thing that I'd like to highlight is that as of July this year, the Australia-New Zealand resuscitation guidelines now include administration of naloxone in those guidelines, which means it's going to be part of routine resus training. And it's fantastic to see I know Paul Dietz has been working on this advocacy for at least 9 years, and it's just borne fruit. So that's congrats for the Australian and New Zealand Research Council. Fantastic to see, and we look to see naloxone and overdose prevention information going out as part of resus training. Look, there are lots of other developments which I don't have time to cover here, all fantastic things in community pharmacies, stuff with prescribed opioid patients, stuff happening in hospital EDs and other departments with drug treatment agencies, and of course prisons and custodial settings, but hopefully some of those we can canvass online. So that's thanks for me. Apologies for any misstatements, and apologies for not being able to fit more in. Thanks.
Great. Thank you so much, Simon. Ellie, over to you.
All right. Thank you, Michael. I am going to be talking about overdose from the peer perspective. So I am someone who uses drugs, heroin in particular, and this is a subject that's close to our heart. I will start by acknowledging the traditional custodians of the lands we are meeting on. I'm on Wurundjeri land in Naarm in Melbourne, and Aboriginal people are disproportionately affected by the harms of the drug laws, including overdose, imprisonment, and all the things that come with having criminalised populations. But I can't talk about this subject without acknowledging my community. We are the front line. We're the people that are affected by overdose. I don't know anyone that hasn't lost many people that they really love, their friends, partners, their chosen family. And many of us have survived overdose, either responding to it or experiencing it ourselves, and we don't always survive unharmed. So I don't want to talk about this without acknowledging the impact that it has on our community. But we have also, as Simon has talked about, we've had a lot of progress in this space. So for many years, I'm old enough to remember when we were doing overdose response without naloxone. We learnt from the drug user organisations how to do mouth-to-mouth breathing, and we were doing that in our community. And then we had the first take-home naloxone program, as Simon already mentioned. So that started in Canberra with the drug user organisation, and I did that training, and it was like a 2-hour training where we would sign up for it, we'd go to it, and then at the end we'd do a test, and a doctor would look at our test and write a prescription, and then the CARMA staff member would run to the pharmacy and get the naloxone and bring it back for all the people who did that training. We've come a long way from there, where we've got now the national take-home naloxone program, where people can get it for free. Anyone in the community can get it. We don't do those super long trainings anymore, and it has been a game changer. And I've done overdose response without naloxone and with it, and it does make all the difference. I've seen also the difference in our community that having naloxone makes, and as we've done the training across Australia, that many people from our community had really bad experiences with overdose response in the past. And since we've been doing it in the community, those attitudes have changed quite a lot. So people aren't so worried about putting their friend into withdrawal. They're not so worried about the police. So now when we're in our harm reduction services, people come and ask for it. And that wasn't the case probably like 10 years ago, probably even 5 years ago. So it is having this massive effect in our communities, where it's saving many people, and it's people from the community who are making those changes. We've also seen changes to the actual drugs that we use. So not just the substances themselves, but also what we're finding in them. And we're seeing nitazines and those other things, the potent synthetic opioids turning up in the kinds of drugs that we didn't used to see them in. Oh man, my cat has to join us. So that's something that our community is very definitely worried about. We didn't used to see young people dying in festivals and nightclubs, but that's happening now, and that's a massive concern for us. It's still obviously not as much as people who are still dying from heroin overdoses and opioid overdoses, but it's an issue that we need to change. And the drug checking services that have started in some of our communities, some states, are an amazing change, but there's still not enough, and they're still not accessible enough for all of the people that need them. The introduction of drug checking in Queensland, that's been the withdrawal of support for that from the Queensland government is really disappointing. And the limited hours, the fact that most states only have one, that's the states that have them, that's still an issue for us. There's still gaps that remain in our ability to access the naloxone program. So some of the legislation and regulations still make it difficult for peer-led services to distribute it, for harm reduction services to distribute it. We have the medication, but we don't have the resources in most places to fund the peers to do the training. They're the ones that are usually getting into the hands of people who witness overdose, and so we need more funding, more resourcing for those actual peer programs and the programs that provide the training. We've taken on this responsibility to keep our friends alive because we have been on the front line. And because we've seen people survive overdose as well, that there's, I think, a need to recognise the impact of acquired brain injury, grief and trauma, and what a toll overdose takes, both fatal and non-fatal overdose. A lot of that continuing concerns about overdose relate to stigma. So people are using alone, and they are the people who are most often having fatal overdoses. They're the people who aren't getting the help that they need. Often people who are leaving prisons and rehabs, when their tolerance is low and it's hard to tell people that you might be using again, that's one of the reasons why we're still having increasing rates of overdose. So we do need to do something about stigma. Our opioid overdose opioid dependence treatment, as Simon said, that should be one of our strongest protections, but we have less and less prescribers providing it, less places available, and too many people are being pushed onto buprenorphine when they don't necessarily want it, or not being allowed to change when it's not working for them. So it's getting harder to get on opioid dependence treatment. And as a protective factor, that should be something that we should all be able to access when we need it. If we're in a regional area, it's almost impossible. And if you're in one of the states where you have to go to a pharmacy 4 or 5 times a week, that you can't have a life outside of that. So we do need to do something about the opioid dependence treatment. And part of that is addressing stigma across the community, in the media and in our health services. So what do we need to do? We need to provide legislative change, ideally legal regulation of drugs and community safe supply, because we should know what we're taking. We should be able to know the strength, what's in the substances that we're using. If we did that, overdoses would possibly stop, but definitely reduce dramatically. And less people would be going to prison. That would be a win for everyone. We need to expand our drug checking services. not just at the festivals, not just in one site, but in every community across the country. Mail-in drug checking could make a difference for those people who are in regional areas. People need to know what they're taking, and that's another way that we could really make a massive difference to that. We need more peer-led services where the first responders, where the trainers, where the people that our community trusts, and without us, the best policies and programs aren't going to reach our community. We need real investment in reducing stigma, not just through campaigns, but actually through structural changes, legal reform, accountability from the media and from politicians and health services, and education across the community. And we need accessible drug treatment that involves real choice, where people have control over their medications and it's accessible in a way that allows you to also work and have a family and get education. So it needs to suit your life. Oh, whoops, sorry. So to finish this, my little rant about overdose, it's not actually easy, and it is traumatic, and it is about our lives and our deaths. But we have taken a massive part of that responsibility, and we've been doing it for decades. We're doing it more and more all the time, and we're doing it really well, I think. And the support from people around us has made a huge difference, but we do need more support. So if we really do want to do something about addressing overdose deaths, then we need to be involved. We need to be leading the responses. We're not just the beneficiaries, we are the service. So thank you.
Thank you so much, Ellie. And our final speaker today, Amanda.
Thanks, Michael. And apologies, everyone. I was having a bit of technical difficulties. My camera has been disabled. I can no longer share video. Ah, there we go. Okay. Now that's not in slideshow version though, is it?
Yeah, we're getting the main screen.
You're just getting it in slideshow?
It's fine.
Okay, great. All right. Well, thank you very much for inviting me to speak today. This is a paper that I worked in collaboration with Emmanuel Mammoliti, who's a PhD student at NDRI. He led this paper, and I also worked with Professor Susie Nelson on this work. I too would also like to acknowledge the traditional custodians of the lands on which I live and work, the Gadigal people of the Eora Nation, who have for thousands of years cared for, fished and lived by the beautiful Cooks River at the bottom of Marrickville. So a couple of key international opioid indicators that really suggest that our opioid markets have shifted substantially, major changes in opium cultivation in Afghanistan, and a lot of instability in Myanmar, which is the other main region that produces opium. And obviously this has had a massive, massive impact on the North American markets, along with regulations around pharmaceutical opioids. We've seen devastatingly high death rates up in that region as a result of a lot of the illicit fentanyls. So we undertook a scoping review to find out what's happening with novel synthetic opioids in Australia and what we think this means for harm reduction. And Elle, you could probably have written my presentation, basically listening to some of the messages that you had. We went through all of the regular and you can read all of the methodology. We went through the regular databases searching for academic literature. We searched over 30 fentanyl terms and over 20 other novel synthetic opioid terms, and we were really interested in where there was a mention of novel synthetic opioids in Australian markets, and obviously it needed to be in Australia. So just going back to what we mean by novel synthetic opioids, we do include illicit manufactured fentanyl along with fentanyl analogues, and there's also a whole host of other NSOs. I've mentioned U4 7700 because that's popped up a little bit in Australia, and also nitazene compounds, and both of these substances were originally developed in labs, but they never made it to market. And apologies, I've missed if someone else has covered this, but obviously we know that these substances are extremely potent, and which means that there's a really, really short window of time to intervene in the event of overdose. Susie and I published a piece in 2022 for the first time documenting how many of our fentanyl deaths in Australia were actually due to illicit fentanyl and fentanyl analogues, and you can see that the vast majority of our deaths still remain pharmaceutical fentanyl deaths, with very small proportions related to the other forms of fentanyl. And I would also point out that we've had a pretty major decline in fentanyl-related deaths. So we found about 40 academic journal articles on NSOs in Australia. You can see that obviously we've been talking in the literature for quite some time in the blue about fentanyl analogues. And then the orange kind of captures a range of other NSOs, and there were reports of a cluster of deaths related to U4 7700 some time back. And then you can see that the real clustering to the right of this graph of the nitazenes in the green. A large chunk of these papers were related to wastewater monitoring, both the national system and also some really specific festival-based testing programs. There weren't a huge number of detections that we found in that time, and only 2 of those NSO detections actually related to nitazenes, occurring from 2022 onwards. The Emerging Drugs Network of Australia has published quite a bit, particularly the crew in Victoria, where they look at emergency department presentations and toxicity presentations. They run the tox, and for some of the patients, they will interview them afterwards. And they've found 30 unique NSO detections between 2020 and 2023, 9 of which were related to nitazenes. And the really great part about this system is that when they do survey people, they can actually ask, did you intend to use nitazenes, or did you purchase it as something else? Which is really important. Mortality is actually a lot more difficult to capture around the NSOs. It's quite time intensive. I did that piece on the fentanyl, novel synthetic opioids, and the nitazene situation is moving so quickly with so many different variants. And for those of us sitting outside of the coronial system, we only have access to closed cases, and many of these cases are still open. But I did a piece with the Coroner's Court of Victoria and wrote a letter to DAR. And at that point, we found 22 nitazene-related deaths in Victoria alone that had happened from 2021 to 2024. And the very recent coroner's report, which may already have been covered, they didn't specify which of the NSOs were involved, but they found 27 of these deaths. And so it's a really kind of fast-moving space. And I guess the other thing that I would say about these drugs is they're very, very hard to capture in any of. I'm involved in a project up at the MSIC drug checking project, looking at equipment testing, and it's very, very difficult for them to kind of calibrate the right signals for all of these different and very new compounds. There was a kind of a major AFP report in October 2024 that said they'd had 47 nitazene detections. We had a quite a large illicitly manufactured fentanyl seizure in late 2023 in Port Melbourne. So we know that it's coming into the country. And then, of course, we've got across the Departments of Health and other alcohol and other drug agencies a range of public drug alerts, which is a really, really important addition, along with the No community, in terms of trying to get the word out earlier. And there's been 51 alerts since 2019. We actually, in fact, in New South Wales had a dance event that was stopped, and there was an announcement made that there were nitazene contaminated MDMA tablets being sold. A couple of people had already been taken by ambulance to hospital on the evening, but it was great that they were able to get the message out really, really quickly. So there's just under a quarter of these that were related to nitazenes, and just over a third NSOs overall. And most of the reports have been about nitazenes contaminating other substances, particularly stimulants. We've had signals, according to our work, for nitazenes in all jurisdictions except Tasmania, although I was very abruptly, well, not abruptly, but rightly pulled up by someone in Tasmania saying, yeah, we're not actually looking for it though, and we don't issue public drug alerts. And of course, there's been some worrying reports recently around nitazene contaminated vapes, young people presenting to emergency department with really, really strange clusters of symptoms after using what they think is cannabis, but of course they're in opioid withdrawal. And it kind of really complicates the clinical response in those cases. And then just a couple of weeks ago, a young Australian man was arrested for selling contaminated liquid vapes, which is really, really problematic. This wasn't in our paper, but it's just work done by NDRI post our published paper looking at nitazene availability on crypto markets. The graph on the right shows the overall proportion of listings that are related to nitazenes. It's less than 0.5%. So there's really not a great influx on these markets. So what does this mean? These drugs are really potent enough for us to be a bit more worried than, you know, we need to respond now. And as Elle was rightly pointing out, we need more drug checking services. We need community-led drug checking services, because the ones that are in existence aren't reaching all of our communities, and particularly those people who are injecting drugs and maybe using opioids but may not want to be using nitazenes. And clearly 2 supervised injecting facilities just on that point isn't enough to really kind of keep us in a safe spot if we see a greater influx of these substances. We do have a really extraordinary take-home naloxone program available across the country, but obviously, as Elle pointed out, there are still access issues, and we also need to figure out how to increase the reach to people who don't use opioids but might actually be buying stimulants and unknowingly using opioids, and how do we communicate that in a way that isn't stigmatising. We also need to know what sort of a demand there is for these substances in Australia. We don't know that. We know in North America that now quite a lot of people do prefer the fentanyls. We know there's some anecdotal evidence that people are buying on crypto markets. And I would also kind of end on reflecting Elle's point that stigma is absolutely harming all of our communities of people who use drugs, so that we absolutely need to tackle that. NSOs are here, they're not here in a major way, but we actually need to be doing something now to expand our reach. And it's the $64 million question of whether they're actually going to become a bit bigger issue. We had the same questions with fentanyl. There's no reason on why they're not more present in our markets, but we actually need to be doing something a bit more proactively now, and I'll leave it there.
Thank you so much, Amanda. I'll ask Simon, Elle, and Amanda to keep turn their cameras on and pop their mics on as well. For those who are able to stick around, we've run a little bit over time, but hopefully this meeting doesn't kick us out and we can hang around for an extra maybe 5 minutes to answer any questions that people in the audience have. Please use the Q&A function online to lodge your questions. In the meantime, I'm going to start with a question for you, Elle. You spoke about limited access to opioid agonist treatment, which would be the front line for, and how protective that is for opioid overdose. You spoke about stigma being a key barrier to access. I was wondering, and touched on a few other things around numbers of prescribers and regional access. I was wondering, would you like an opportunity to expand on any ways that you think we could be improving access to opioid agonist treatment?
That is a hard question. There are a lot of people that are looking at this. I've always wondered if the kind of additional restrictions that we put on doctors and the additional bureaucracy that we have around it does put off some prescribers and some pharmacies from taking part in the program. But I do think a lot of it is ultimately about stigma, and without addressing that, it's never going to change. There'll always be reasons for people to not want us in their waiting rooms and not there with their other clients and things like that. So yeah, I think stigma is underneath almost everything.
Yeah, sure. Not getting any questions in the Q&A at this stage, so I'll keep going then. Amanda, so you've presented some deaths on nitazenes from Victoria primarily. Do we have much of a sense of what may be happening in other states, or is it that we're not really looking on for nitazene deaths in other jurisdictions?
Well, it's really complicated because as researchers, we don't get access to the closed cases. So all of the cases, many of these cases will be sitting as open because they've probably got to go through the investigation process. I mean, I don't know if this is too blunt a measure, but I would hazard a guess that the public drug alerts are probably a pretty good indicator of what's going on in each jurisdiction. We've had lots and lots of traffic in New South Wales, so there'll be deaths happening in New South Wales. There's been a few media reports of deaths in New South Wales, so they're definitely happening in New South Wales. And yeah, possibly in other jurisdictions where I think Queensland's another one that comes up for quite a high number of drug alerts and clearly, you know, relatively high numbers of seizures in Queensland. So as blunt as that might be, like I can go and search tomorrow for nitazene-related deaths across the country, but it's going to be really incomplete, and we need to be really careful about that because there'll still be a whole bunch that are sitting unclosed and still being investigated.
Thanks, Amanda. And Simon, you noted that people who had been attended to by police and revived with naloxone via that police training program had fairly positive experiences of that, which I guess is, you know, a lot of the research I've read and people that I've spoken to are quite concerned about police attending to overdose events and potential arrest and legal ramifications. I guess, I mean, I have lots of questions about that, but I guess I'm wondering, are there any sort of formal plans to try and disseminate those positive experiences, but also, I guess, to be checking that those experiences are remaining positive?
Yeah, good question, Michael. Look, first thing to say is that what we're seeing from police is that they're treating these events as primarily health events, and they're often the first people on the scene. And so they're not just there to bust people, and that's what's important. In terms of dissemination, look, WA Police have been keen to talk to people from around the country about their experience of running these programs. I mean, we've got lots of quotes within our within our reports on the experiences that went down, which are worth having a look at. But we also know from speaking to people at Peer-Based Harm Reduction WA that, you know, as I said, a lot of their consumers are also reporting positive experiences around police attendance and these revivals, which is fantastic. So, yeah, while there's an understandable history of you know, people who use drugs being concerned about police attending at overdose events, this is more where police come across someone who's overdosed and are able to then intervene with naloxone in a way that they weren't able to beforehand. So issues around concern and policing exist, but you know, what we're finding in WA is that this program, health-focused, police saving lives, has really turned the discussion around in a way that we haven't seen before.
Can I add something to that, Michael?
Please.
I was one of those people that was concerned about the police carrying naloxone, and I've heard the same things from WA about it changing the relationship of how police approach an overdose. And like, you know, from our work down at North Richmond Community Health, how police sometimes would come to overdoses and be the law enforcer. Others that would sometimes come and just not know what to do and maybe want to help but be like a bit confused about what their role was, or not really understand how to respond to the overdose. And it does sound like this new role that they're taking on has just changed them into being health responders that feel like that know what to do, I guess, and are acting on overdoses in a different way from how they used to approach them. So it sounds positive from everything that I've heard as well.
Yeah, I think that's the case, Elle. And the other thing I'd say is there's a YouTube video up. If you search WA Police naloxone, it was at the launch, and there's some great camera footage of police, you know, intervening and saving lives, and also some discussion from police about their attitude changes and support for the scheme. So if you haven't seen that, it's worth doing. And any police around the country, I would really encourage you to interact with WA Police about this really super important overdose prevention and treatment initiative.
Right. I think we've got time for one more question that's there in the chat. It's a question from Deborah. She's asking, and so I'll direct this to you first, Amanda, whether you're able to comment on the need for extra naloxone for nitazine overdoses. But Elle and Simon, free to chime in as well.
Yeah, look, I mean, I'll take a first crack at it, but Elle and Simon might also be able to respond. My understanding is that it's not always is the case. Is it necessary that you need extra naloxone? I think there's there's a bit of a myth out there that naloxone doesn't work for these drugs. It does, and in some cases it may need additional doses of naloxone, but that might be with any other of the NSOs. But Elle and Simon, you may have more expertise on that one.
Nothing from me that would add to what you've said, Amanda.
Yeah. I just think we need to be clear that it works. Sorry, Elle.
Yeah, no, I agree with that. I think it's the same as like any opioid overdose. Some need one, some need more doses, but I think some of those barriers to distributing naloxone that we've had over the last few years are a problem, and we should be able to distribute as much as the person wants, basically. Like offer to take a couple of packs home for people when you can distribute it. I understand that it will be easier for those supply issues to be reduced from now on, but some of those regulatory barriers are still there. So they're being addressed, I think, in most states. So hopefully that's not going to be an issue for much longer.
Can I just say, Elle, to add to that, there's a kind of a reverse stigma of accessing naloxone in that one of my colleagues went into a pharmacy in North Richmond to get some naloxone, and the pharmacist said, "What do you want naloxone for?" Said person wasn't a person who was attending the MSIR. Said person just wanted to have naloxone because they hang out with people who use other drugs that might contain opioids unwittingly, And they wouldn't provide naloxone. They went through all these questions, and my colleague just walked out me, and it's like, well, that's not helpful, is it?
Yeah, wow.
Well,
I
anyway.
do think, yeah, I guess one of the things I didn't mention was that not every pharmacy is signed up for the program. Not all of them understand overdose. I do think peer programs are generally a bit better at distributing naloxone than many pharmacies. Sorry, I just jumped in. Go, Simon.
That's okay. Look, I think Susie Nielsen might be online, but I know from speaking to Susie that the number of pharmacies now, I think it's about 75% of Australian pharmacies now carrying naloxone. So the numbers have been growing, proportions been growing over time. And there's been a number of interventions that have been done and rolled out within community pharmacy to address stigma, provide information about, improving responses at a pharmacy level. So it's not perfect, but I think it's a hell of a lot better than it was, and it's growing. So, these are work in progress, and clearly not everyone's going to be at the same point, but work's being done to improve things, and there has been improvement over time. I can just see a question from Kelly Menon online, who works at WA Community Country Health Service. She's doing fantastic lobbying, trying to get naloxone into hospital pharmacies and meeting some barriers. Yeah, Kelly, I'd approach you to reach out to the Mental Health Commission, who are coordinating things statewide, and will be able to provide you with support. But great work that you're doing there. Reach out to the Mental Health Commission.
Thanks, Simon. Yeah, I saw that question pop up just after I said that I was going to close it at that one. So I was going to make sure that got answered. I will add as well, Kelly, that I believe there's been some very recent developments around naloxone being incorporated into resuscitation guidelines. Amanda, is that ringing any bells? I know Paul's mentioned it a couple of times in some meetings.
Sorry, say that again. Naloxone.
Michael, I'll cut across you. I mentioned that in my presentation, the last slide. So I gave those new resus guidelines, and it's there. Yeah. So look it up online, Resus Council, new guidelines, training, etc.
Yeah, fantastic. Thank you so much, Simon, Elle, and Amanda, for presenting today. And just before we finish up, I would just like to put on the screen some details for the NDRI September webinar, which will be facilitated by Dr. Nick Taylor. And that webinar is titled Young People, Alcohol and Risk, Understanding Recent Declines in Youth Drinking. And I'll just leave that slide up on the screen. If you'd like to scan the QR code, you can either register directly or take down the NDRI email address and be added to the NDRI email list. Thank you again to each of our speakers for today, and have a great day, everyone.